My name is Michelle Andwele, and I'm the Senior Director for Health Promotion with the Arthritis Foundation. It is my pleasure to speak to Dr. Mara Becker. Dr. Becker is a professor of medicine, pediatrics, and the vice chair for faculty in the Department of Pediatrics at Duke University School of Medicine. Her research interest is to identify factors that enhance response and minimize toxicity to drugs used for the treatment of diseases in children. Dr. Becker is involved in several national committees, including the American College of Rheumatology, the American Board of Pediatrics Rheumatology Subboard, and the Childhood Arthritis and Rheumatology Research Alliance. Welcome, Dr. Becker.
Thank you. Thank you so much for having me.
So, of course, Dr. Becker, we're going to start with a conversation about COVID. It seems as if COVID has been with us forever, but we're getting to the year and a half, almost 2-year mark. So yes, still a long time. So based on all that has transpired over this time frame, what should parents know as it relates to outcomes for kids with pediatric rheumatic diseases who get COVID?
Well, remarkably, as disruptive as COVID has been to all of us on this planet, I think we're all constantly remarkably surprised with how well our patients have done despite the pandemic. Meaning that there have been very few patients that have had complications from COVID. Those that do actually have COVID-related multi-inflammatory system dysfunction or inflammatory system. I'll start that sentence again. Children who do have the rare hyperinflammatory syndrome post-COVID actually do recover, which is remarkable. And amazingly, I think what's most reassuring to us is that based on very rapid accumulation of data, we're able to identify and develop guidelines about how medication might need to be held should children actually get COVID, or even more importantly, when it's time for them to receive their vaccines. So I think, the silver lining for us is that overall, the children, even immune suppressed children, even with children with immune dysfunction, actually do pretty well and haven't had any untoward significant concerns surrounding COVID. We're very cautious. We hold medications when necessary, of course, and those are all based on the guidelines from the CDC, as well as experience that continues to get generated worldwide. But so far, I'm cautiously optimistic that as a whole, as a cohort of patients that we've all been very concerned about due to the fact that they oftentimes require medicines that will decrease the immune system. In fact, they've actually done quite well. And so I guess there's a silver lining there when it comes to COVID.
That's very reassuring and really positive news for parents. So let's talk about vaccines. You mentioned vaccines. So there are kind of two conversations happening now. One is, what have you seen in your clinical practice or from your research for kids 12 to 16 who have taken their COVID vaccine? How are they faring, and what their adverse effects or any concerns?
Well, in fact, I'd say they are faring quite well. Everyone from my own children who have received it to the patients that we manage that have received it have actually done incredibly well. And without question, knowing how significant and unpredictable just getting sick with COVID can be, having the ability to be vaccinated is by far one of the most important strategies that we can offer to help mitigate that risk. And so thankfully, at this point, we haven't experienced any children having significant side effects from the vaccine at all, other than a sore arm or potentially a day of feeling a little bit blah. But we're actually all very optimistic and excited for the hopefully soon release of the ability to give vaccines to even younger children.
Yes, the Pfizer EUA, that's kind of working its way through the FDA now.
Yes, so we're just waiting.
A lot of positive news for parents who I know have been waiting.
Indeed.
All right, so let's move on and talk a little bit about therapeutics. I'd like to talk first about biologics, and then we can have a little conversation around the non-biological like methotrexate. Okay. So optimizing therapies is what every parent wants for their child. So what do we know that would kind of guide parents in terms of the questions they should ask or anything that they could do to create an environment that a biologic is optimized for their child?
Yeah, there's been some really interesting data that have been coming out, and I'd say not just this year, even though there's some interesting papers that have come out this year, but even within the last several years that have shown us that, children who have their arthritis well controlled sooner, and I say sooner in the course of once they start to develop symptoms, have actually been shown to do much better in the long term, meaning getting into remission sooner, having less long-term sequelae or disability or difficulties with their joints. And I think that's been a real therapeutic change, even since I was training like 20 years ago, where we might be cautious or concerned or say, okay, a little bit of improvement is enough. When in fact, what we're starting to recognize is that children who have very rapid improvement or quick improvement early on may indeed fare better as they're adults and as they age. So I think overall, if I were a parent, I would talk to the doctor and say, okay, how do I get my child's arthritis under control as quickly as possible and as safely as possible, of course, within the context of, the values of the family and the comfort level of the family. But truthfully, I think we are starting to recognize that having arthritis that goes undertreated or untreated for long periods of time has consequences later on. And we really strive to do a better job treating children quickly and effectively as much as we can. And so what the right treatment is probably the harder thing to decide. And as you mentioned about biologics versus non-biologics, we don't have a secret weapon yet to know what medicine is the perfect medicine for each child. But what we do know is that effective treatment is a key. And so if we have a good response to medication quickly, that the chances of that child doing well long-term are better. And that goes for inflammation of the eye, which can sometimes happen with arthritis, as you know, to long-term joint pain, ongoing disease activity, or ongoing arthritis into adulthood. So I think overall, we tend to want to be, for lack of a better word, maybe more aggressive or more upfront about trying to treat that arthritis early so that we are effective long-term. So I think that's probably, and that data continues to be reinforced in even the literature that's coming out this year. What I thought was also pretty interesting is that we still see some variability. Some children who take a little bit longer to get better, some who have rapid improvement. And indeed, what it's starting to look like is that the earlier administration of effective treatment, whether that be a biologic or a non-biologic DMARD, is the key. And that if you're able to find that right medication early on and they do very, very well quickly, that they actually have a much better trajectory long-term, like a year later or 2 years later, which is reassuring to me that there are strategies that we can implement up front to try to help children long-term.
So Dr. Becker, what role does treat to target play in that conversation?
Oh, it's a great one. So, treat to target is almost a systematic way of dialoguing with the patient and the provider, if you will, that you have a guide to say, all right, we are trying to get your disease activity low to a score of X, right, that you discussed. Usually it's via something called the Juvenile Arthritis Disease Activity Index, or the JADOS. And so we know that children who have very inactive disease have a very low score. And so you try to treat and escalate treatment in a very systematic way to achieve a low score. But the secret sauce, I think, really is the conversation that you have with families. So each time you can show them and say, okay, we started off maybe at a score of 10 and we're seeing a score of 50, but we're still trying to get to an improvement of 2.5. We're still trying to get a lower score. So we need to escalate your treatment. And that conversation, I think, is really powerful, right? It should be a communication. It should be a shared decision-making, hopefully, ideally, with a goal, a target in mind. And that's where I think treat to target is very powerful, because it really leaves subjectivity out of it. It makes it more objective, and you're really seeking that ideal, optimal improvement.
That's great. That's great to understand. So let's shift gears a little bit, even though we're still in the therapeutic conversation, and talk about clinical trials. We know that clinical trial fuels innovation, but there are always some concerns or reticence on the part of adult patients as well, but parents probably even more specifically because their child is young. Do you have any advice, any words of wisdom for parents as it relates to these particular concerns?
Sure. So I totally, I get that. I think that there's unfortunately, and for probably some good reason, natural reluctance around research because it's, I really am I always struggle when families jump to the conclusion that we're experimenting on their children, when indeed that's not the case. In fact, without research, we're practicing with no data, which is way scarier. And sometimes I like to frame it for families to say, children have been neglected, I think, in research for years. And it is our obligation, and I'm proud to participate in research to be able to offer children the most cutting edge therapies in the safest and most regulated way possible. But every family has to feel comfortable with that. No one would ever be forced into research. It has to, again, be an endeavor that they enter into with trust with their physician and the study team, of course. But most importantly, I think they have to recognize that, or I'd like families to recognize that it's so critical for us to be able to approve the best medicines for children, to show that they're safe and effective, and to provide data. When they ask me all the questions about what are the chances of my children going into remission, or what's the child going to remission, or what's the chance that this medicine is going to work for my child, without that research, we don't have that information. And it gets really challenging to guide families and to have expert opinion when there's no data to drive it. So it is, I understand some hesitation when it comes to feeling like it's part of an experiment, because that's the way we have to voice it. But in fact, it can be very powerful. And it can be a really important piece of us moving the field forward. And I think we have in so many ways over the last 2 decades, coming from the pre-biologic era to the biologic era. There are so many more options. And, research isn't just about therapeutics. It's also about quality of life and how families are feeling on those medicines and how the kids perceive their disease, right? There's so much more to research than just a randomized clinical trial. And I think all of that is really important for us to best optimize the way we treat and manage children and their families who are diagnosed with rheumatic diseases. So I think it escalates and elevates the quality of the care that we provide if we offer that as an opportunity to families who are getting clinical care from us in the clinical domain.
Dr. Becker, I really like the way you connected kind of the laboratory environment to the larger care conversation. That is really fueling the opportunity for physicians such as yourself to optimize care, and research is part of that conversation. So thank you for making that kind of connection to the real world application of taking care of my child. So let's close out our conversation, Dr. Becker, talking a little bit about disparities in pediatric rheumatology. What are you seeing, and what are some of the kind of ways forward as we continue to focus, nationally on healthcare disparities, but really honing in on the pediatric population?
Sure. I mean, I imagine, well, I've certainly had an awakening over the last few years, and I think I imagine everybody has. But what has been surprising to me, I think, even in reviewing the literature for the year in review, was that there are still disparities in the patients that we manage, disparities in the amount of arthritis that comes through our door, and children of color who may have worse disease when they enter, even despite everything else being the same, and that there's improvement, but there's still differences that remain over time. Also differences in inflammatory responses for Black children compared to white children who have Kawasaki disease. And there might be some impact and influence of really social determinants of health and geography and where families actually live. So our, pediatric rheumatology is a tough one. We're a small field. We don't have a lot of resources. And so the truth is we have to be challenged with reaching our children in rural areas or in states that don't have a lot of representation baseline. This adds a layer of complexity to the fact that we have to be, I think, tenacious to recognize where there are inequities. And first, we have to be aware of it, that they exist, whether we want to believe it or not. And then I think we have to be tenacious in identifying them and trying to equalize them. I think social determinants of health are a big contributor. Some of the data that's coming out on adverse childhood experiences, or ACEs, is really remarkable, and that children who have arthritis are much more likely to experience adverse child events in early childhood compared to those that don't. So when it comes to solving these problems, I think awareness is first key, but then the truth of the matter is, I think as we start to develop research programs and we start to develop clinical programs, keeping that lens from the beginning to the end and how we can provide the most equitable care is going to be paramount, right? And that might mean that we have to wake up a little bit and recognize that programs that we develop that children can't get to aren't going to be good for everyone. And how do we ensure that the care that we provide gets out to domains where there might be healthcare deserts or areas that children cannot receive maybe quick or optimal primary care to identify rheumatic disease. So I think we have a lot of challenges ahead of ourselves, but the truth is, I mean, I think everyone in healthcare does. The beauty about, I think, this field is you have passionate providers from all over the country that are really committed to taking care of children with arthritis and other rheumatic diseases. And we're used to being small but mighty. And I think the truth is we have to up our game and ensure that we are not leaving behind children who might be at a disadvantage due to race or where they live or what their socioeconomic status is. So I'm really proud of the work that's been going on in this field, illuminating some of those differences so that we can see them. And now we have a target that we can address and improve. But it's going to take all of us committed to it in every domain, I think, to really make a difference, from educating our fellows to be thinking about this vantage point and all of the work that they do, to the type of services that we provide and how we provide them, to the research that we design. So just the beginning, but I anticipate that, like most things that we tackle as a field, we'll continue to forge ahead and hopefully move the needle.
Dr. Becker, thank you so much for taking the time to talk to us. It's really interesting to hear about the multi-pronged approach, and we know that you're setting a clear path forward. So at the Arthritis Foundation, we look forward to collaborating with physicians such as yourself to serve communities of color.
Thank
you.
It's been a pleasure.